So welcome everyone to the ACP Long COVID Interest Group. My name is Nicholas Franco, and I'm one of the coordinators of the group, along with Dr. Chopra. Um, Today we have a fantastic guest who's a physical therapist. And before we introduce them, I'd just like uh, to direct everyone to the chat, and there is a RedCap link for a survey that we're doing to understand the impacts of these sessions. It's very short. It's basically 5 questions, and we ask that you fill it out before and after. It's the same 5 questions, so it's super short. It really helps us understand the impact of these meetings, and I think it's a just for us, it's an important way to kind of gauge how we can improve. So, with that, I will head over to Dr. Chopra and let her introduce our guest.
Thank you, Nick. I'm Anita Chopra. I am an internist and a physician at the Long COVID Clinic here at University of Washington. This group is actually driven by all of you because we try and get feedback from you as to what you want to see. And this survey is one step in that direction. And one of the things that you guys have requested a whole lot is to have a physical therapy expert and to invite them and to talk to them about what are some of the rehab strategies to manage these patients. And our physical therapy colleagues are really integral to our multidisciplinary team. And I'm so very excited and honored to have Bryan Simpson today with us here. Bryan is a physical therapist who has his practice in Mount Lake Terrace. He specializes in managing chronic conditions like ME/CFS, chronic fatigue, long COVID. He also helps us in managing patients of different phenotypes with long COVID, including dysautonomia and as well as brain fog and chronic fatigue. Bryan, in addition, is also an expert in managing balance issues as well as sports medicine or sports injuries. Welcome, Bryan.
Thank you. Good to be here.
So Bryan has been seeing long COVID patients as long as we have at the University of Washington. It's been 5+ years. And I remember when we started referring patients to Bryan, he actually went ahead and not only got training himself, but also trained his entire staff in managing these patients. So I'm very, very grateful, Bryan, for your expertise. So I will start off by asking you, Bryan, when we refer patients to you in for our long COVID patients, what we are thinking is when I see a patient with chronic fatigue, patient is complaining of long-term fatigue and post-exertional malaise, the first thing I talk to them about is pacing and working with a physical therapist. What is it that is helpful to you when you see those referrals that we send for these patients? What helps you?
Um, so a lot of times we're not the first stop, obviously. They've generally gone to the UW clinic or they've found us online. And a lot of these folks they've been on a journey. So any information that kind of tells us about what that journey's been like, if they've had imaging, if they've had other like diagnostic exams, other diagnoses, and then what types of medications that they're on as well. Some of those will interact with their ability to exercise. Um, but yeah, essentially anything that gives us a clue to kind of like how long have they been dealing with the diagnosis. Sometimes it's on the second infection, was it in 22, 25, 2020, the original COVID virus. So yeah, any of the little details that kind of give us an idea of kind of what they've already been through as far as diagnostics go, and the timeline is really helpful.
Bryan, just branching off from this same question, when somebody who has long COVID comes and sees you in the clinic, what are some of the things that you typically see? What do they complain about? If you can talk about your first impressions of seeing patients with long COVID.
Yeah, usually it's the chronic fatigue people that tend to come, and their biggest complaint is that they go to the grocery store and then they like sleep for 4 days, right? Um, and so a lot of it is like their subjective complaints are I can't do any of the things that I need to do, and everybody's got a different situation. Some people have got little kids, some people are single. I had one guy who was a firefighter, one was a teacher, piano teacher. If you have any kind of like a high exertion job, that can make it pretty challenging. And so, yeah, but mostly people are complaining about they were at this baseline and now they're here and they just cannot get back to that. And so that tends to be the biggest complaint.
Nice. And then for thinking about how to address these patients, for folks who have attended some of our previous sessions, we've heard different guests talk about like modified exercise plans. Could you talk a little bit about kind of what your usual general plan is for addressing these patients?
Sure. Yeah, so like a typical orthopedic exam, you're going to look at range of motion and strength. And you can't you can't really measure those things and get accurate data with the long COVID patients. So usually I spend a lot of time figuring out what was their previous level of function, where are they at now, and then generally speaking, the best thing is education and then cardiovascular exercise. And so I figure out what do you have available to you? Like, do you have a treadmill at home? You got a bike, stairs? Do you walk the dog? And then from there, kind of figure out where kind of what is their limit? Because every one of these people will have a they'll have had episodes where they've pushed themselves too hard and figuring out what is that limit and then what is like the intermediate because basically what I end up teaching people is it's kind of similar to like strength training. If somebody's not very good they're not very strong, I basically what you do is you approach their limit and then you rest and you approach it again and you rest and each time you do that you kind of push the envelope just a little bit, right? And so kind of take the same approach with the chronic fatigue syndrome that comes along with that. And so I kind of figure out what are the tools that they have at their disposal, and then I give them usually I tend to underdose on the first time. So, let's see if you can only walk for 10 minutes. Let's walk for 5. Try to monitor your heart rate. And if you can get, usually most people, I try to do about 50% of the heart rate max if I can, just to kind of like see what that is like. Sometimes people are spending more time looking at their watch and we go to a different method. But yeah, usually I figure out what's their baseline, and then we try to slowly increase that over the course of time. And so generally, what I'll do is I'll say figure out whatever they can do, what access they have to exercise equipment or even just walking around the neighborhood, walking the dog. Um, and then we figure out like if you walk 3 blocks, what does that do to you that the rest of the day and the following day? Um, and then we create a plan from there. So what I tell people, so we're kind of trying to figure out what your limit is, kind of like wave at it almost, and then go back and rest. And the thing that's kind of tricky about long COVID is that it tends to be a moving target. Sometimes people are fine one day, and the next day they can't even get out of bed. So you have to be kind of respectful of that, and not push it too much because um, it can really set people back. But that's kind of what we do, if that makes sense.
I think what you said really just rung so true. You talked about validating their symptoms and respecting their, how much they can achieve. You talked about moving target. That is so well put because patients, their energy levels are not the same every day.
Mhm.
Things that can set them back, like infections or, exerting themselves a lot, or even stress, any form of stress, physical, emotional, or environmental, can actually set them back and can, push back their progress. So Bryan, just, talking a little bit more about this, when we tell them to pace themselves and conserve energy, what does it look like at your end? You talked about heart rate below a certain threshold. We tell them theoretically, please, we will, you should keep your heart rate below 120. But you talked about heart rate, the goal is 50%. Can you talk a little bit about pacing, what does it look like when you talk about pacing to them? How much exertion do you start with? And what are your levels of advancement?
Yeah, so it it really kind of depends on the patient and what their baseline is, right? So, for instance, if somebody can go to the grocery store or they can walk for 30 minutes and they're kind of tired afterwards, but they can get through the rest of the day, that's kind of where that's where I tend to start. So if we're using that, um, usually I'll have them add. It kind of depends on what's reasonable. Sometimes you add time. So if they can only do 10 minutes of walking, I say, okay, we'll add a minute or two each time you go out. And you try to keep the same intensity. Again, if you have to be kind of respectful of the fact that the symptoms vary day to day pretty commonly. And so if you're having a bad day, that's not really the day to push. So generally what I try to say is that we're not only trying to increase your ceiling, but we're trying to limit your floor from dropping at the same time. Um, and so to do even just a little bit, as long as it doesn't totally cook you for, 3 days, that's kind of the goal. As far as pacing goes, it's a little tricky because it is a moving target, but if it was nice and linear, you know, maybe like 3 to 10% each time, closer to three, really, as far as like how much you're challenging yourself. So, we go from 5 minutes to like 5.5, from 30 minutes to like 33, 35, somewhere in there. Um, and then, yeah, generally for cardiovascular exercise, it's like 65 to 85% of your heart rate maximum it tends to be where you want to operate for 30 minutes. Like I said, I tend to underdose for the first time, especially. So about usually most people end up being right around that 100 to 110 beats per minute, 90 to 110. And so it's nice if they've got a treadmill or a recumbent bike or something, because then you can just sit there and look at the heart rate monitor. Some of them have that on the equipment. Um, and then they'll try to operate for their 10 minutes or so at that 100 beats per minute or so, and then see what the rest of the day, the next day, tends to look like. If that goes well, great. You try a little bit more. Usually I start with time more, try to increase the time first. And then when they get to the place where they're doing like 45 minutes, I don't know about you, I get bored if I'm doing much more than that. So um, I tend to change the heart rate next, after they get to that point. So rather than being at 100, they'll go to 105. Does that make sense?
It does make sense. And I think just for our audience, you talked about recumbent bike and they tend to tolerate exercises which put them in a horizontal, position rather than being
Yes.
vertical, because especially people who have dysautonomia, they experience sudden heart racing. And when they are doing exercises which are recumbent, they tend to tolerate them well.
Hmm.
So I think there are a lot of things that you said are really very, very important points to remember. The moving target one, conserving the energy, the heart rate, increment that you talked about, and the fact that they will have good days and bad days. So, let's say they are working, on their pacing and physical therapy for a month, and then so we do not suddenly expect them to run a sprint.
Yeah.
So that's something very important to remember. Um, Nick, please go ahead with the next question.
Yeah, I actually just had a follow-up on that. When it comes to recommending exercise outside of their prescribed PT exercises, have you found that certain activities or things are better for these patients than others?
It's a good question. It kind of depends on where their floor is. So this firefighter that I was talking about, he was having a hard time going back to firefighting, but he was lifting weights all day long. And so some people are generally most people from what I've seen, just anecdotally, um, is people tend to tolerate strength training fairly well. For the folks who can't be out of supine to exercise, those ones we'll just even just sitting up is enough to get your heart racing sometimes. So we'll do stuff in seated. Um, but that's a tough question to answer because it's so variable. It just depends on what the person can tolerate. Um, but generally speaking, like your typical PT exercises. So like your bridges and your clamshells and stuff like that. That stuff is generally they can do that. And if people are just itching to move, I'm like, okay, well, let's do something. Um, that's not going to totally aggravate your chronic fatigue syndrome. I don't know if I answered your question.
No, I think that makes a lot of sense. Thanks. Let's see here. I can also ask, so in terms of what you've seen with these patients, what I guess what do they find the hardest aspect to deal with in kind of keeping with their training plans and keeping kind of with the protocols?
Yeah. So I'll say this to my evals when they come in. The people who have the hardest time are the very type A people who have never been they've never been limited by anything before. They just are determined that they're going to get better, and they just keep smashing their head against the wall, and it just doesn't work. And if you've never been just flat out defeated by something like that, that's very challenging, and a lot of people have a hard time with that. Just emotionally, because it's kind of like been their identity for their whole life, and all of a sudden they just can't use the strategy that they used to use. Just hard work and determination is just not going to work. So I think just adapting to that, and kind of like I said earlier, just being respectful that the it's just going to do what it's going to do, and you can't really force your way out of it. That can be really frustrating.
Brian, we talked about the chronic fatigue. I want to, talk a little bit about post-exertional malaise. Now, post-exertional malaise is really difficult for patients, especially who have led a very, very active lifestyle. Like you said, they were very active before. They would run, few miles a day, and now a trip to the grocery store can put them in bed for days.
Yeah.
So with the post-exertional malaise, it's really difficult for us to manage as well in the clinic when we are talking to them about different strategies. How do you, when you are doing the intake with them, are there any, sort of intake, sort of patient reported outcome measures that you
Mm.
see? Are there any intake forms that you ask them to fill out? Are there certain activities that you set their parameters or framework in? How do you deal, especially that I'm curious about post-exertional malaise?
Yeah, I don't have a great measure for that. Most of the stuff, particularly with our electronic medical record system, is oriented towards orthopedic stuff. There is one. So usually I'll use what's called an lower extremity functional scale, which is it's frankly just not a very not a very good measure for these particular patients. Because it's all related to, can you run, can you hop, and those kinds of things. They're like, no, I can't do that, and I would like to be able to, but it doesn't measure the change very well. Um, and so there is one that's like a self-reported one where you create your own. I don't know the stats on it. I don't think they're very good, but the short version is no, I don't have a great measure. It tends to be more subjective reporting, and kind of like I mentioned in the first question, the there's not great like quick exam stuff. It tends to be more subjective. So as far as like what you're going to find. So that's usually what I do is how I'll try to measure that on their initial visit. Like what's your what's your threshold before you hit that um post exertional malaise. So if it's an hour of like being social, okay, there we go. We've got our measure, and then we'll measure that again at the follow-up visit 6 weeks later if we get another one. Sometimes people just come the one time.
Brian, I want to talk a little bit about now, a little sort of a message on the hopeful side. So I had this one lady that I just saw in clinic who had seen you, and she has really improved. She's about at 80% of her previous functionality. She's not on any medication, and she's a young woman. And she told me how working with pacing, working with physical therapy, she was able to get to about 80%. Now, somebody who is improving, right? We do have positive stories of improvement and hope as well. What do you advise them in terms of avoiding crashes, in terms of continuing these exercise level? Is there a treatment plan for them as well? And if so, what is it?
Yeah. It's very individualized because everybody's so different. It's such a spectrum of how limited people are. Um, so usually I just kind of cater it to I just like I was just talking about in the last question. What is your level before you hit that post-exertion malaise, and how long can you go for whatever the thing is, right? And so generally, and I kind of do this across the board with all of my patients. If how are you doing like this week with this particular activity, and you try to modify it so it's the plan stays specific to the person each time. So it's not necessarily generalized across the board. Um, but generally that kind of like 3 to 5% of like increasing the intensity each time is just kind of like a general outline. Um, So yeah, but like I said, it's fairly individualized, and it just kind of depends on what people are, where they are. But usually it's a lot of coaching, and there's a lot of you need to be patient, and usually by the time they get to me, they've figured out that their own strategies don't really work. Um, some people have a harder time with that than others. So just consistent encouragement tends to go a long way. And then usually by the time they can see the progress, so the people who are at 80%, they kind of know it's like, okay, this is just the way that it's going to go. And as long as I stay consistent with that, and you're just trying to like approach your limit without exceeding it. Um, and then you do a little bit more each time. It's interesting because some people have different symptoms, and so usually there's some kind of clue that the patient will have that they're going to hit their post-exertional malaise limit. Some people had one lady who got like shivers. Some people they'll get like a fever. But there's usually some kind of a clue that the person has. So I'll try to figure out what that is. If some people don't have that, and you just kind of go based on what their symptoms are. Um, But yeah, usually there's the plan kind of identifies itself as you go through it with the patient.
This is very significant what you said that someone had the shivers and someone got fever, so they can all be part of the post-exertional malaise picture.
Yeah.
Bryan, my last question before we wrap up today. I know that you have to go early, but the last question is about balance issues. I did send this patient to you who you saw with balance problems, and so she felt unsteady all the time. Symptoms were like vertigo and like sitting on a boat.
Mhm.
This can be part of either can be a manifestation of vertigo or can also be seen in dysautonomia like pictures with long COVID patients. What is your experience in those patients? For example, this one gentleman I have who I have been following for over a year, his vertigo was so severe he could not go out of the house.
Mm.
So he has not been able to get physical therapy. Finally, now after a year, he's slowly improving enough to be able to venture out of the house. So, what is your experience with these patients, with the patients with
Yeah.
balance issues and dysautonomia type features?
Yeah. So yeah, it does tend to be multi-system. And some people do get the vestibular type of symptoms, almost like a concussion or something like that. And so it's kind of similar. I kind of take a similar approach as far as like approaching the person's limit. So usually with those folks, I'll say, "Hey, what are your symptoms like?" And I don't really want to exceed more than like a 3 or a 4 out of 10. Um, and then there are certain strategies you can do. I'll just show you like a quick little one. So because the vestibular system and the visual system are so interconnected with the how the brain is moving and interpreting all the information, typically if you look really far away into the distance, it makes it easier for your visual system. Um, and then applying some pressure on top of your head gives your entire system a little bit more proprioceptive input. And that can kind of settle some of the symptoms down just a touch, to the point where they can, not be so, you feel kind of icky if you have something like that. Um, so sometimes it's just standing on one foot. Sometimes you're standing on a pillow and then like interfering with a proprioceptive input. Other times I'll use like a VOR. So like I'll have them, you hold your thumb out ahead of you and you turn your head back and forth while you look at it. You can do it to a metronome and that helps it to be a little bit more regimented. But if different from like your typical vestibular hypofunction, again, that if you can rock the boat pretty severely and then they suffer for days. So starting small, kind of underdosing, and like 3 out of 10 as far as symptoms go, is kind of what I'm looking for. And there's a lot of different ways that you can do that. It just kind of depends on what their floor is at, what type of symptoms they have, how's their visual system, how's their proprioceptive system, and it's again, it's all very interconnected. So.
That was very, very helpful. And at this point, before we wrap up, if there's a question from the audience, we will definitely take it. And if not, we can also forward your questions to Bryan. But Bryan, this was very, very helpful to know what is going on the other side when we are referring these patients to you and what they are experiencing, how you are working with them on their journey. And thankfully, a lot of our patients have improved, which is wonderful, and but some have not. And I think that we are all discovering more and more about this condition, and it will be a work in progress. But I thank you for your partnership in managing these very
Yeah.
challenging patients and for your contribution in, making them at least feel somewhat better. Thank you very, very much.
Yeah, of course, of course. I think one thing that I would say is that, and this is kind of true across the board, not just with physical therapy, but I'm sure with all medicine, but a lot of people are just looking for validation. And when they can tell you're listening to them, God, it makes a huge difference. And to hear some of the same story or some of the same symptoms that they've been experiencing, a lot of times a little bit goes a really long way. So yeah, like I said, happy to take any questions if you guys have any.
And I'm just going to jump in real quick before that, just to say, if you're able to, thank you to everyone who filled out the survey. If you're able to fill out the kind of survey on the way out, that again really helps us understand the impact of these changes. So that same link should open the exact same survey, and we just have you fill it out before and after. So thanks again to everyone who did that.
Thank you very much, and please keep sending us suggestions and feedback. And if there is some specialist that you really want to hear from, we would love to invite them because I feel that this way we empower each other and learn a whole lot in terms of management of these patients. Thank you, Bryan, for coming today. This will be recorded and be available on our website as well. Thank you very much.
No problem. Thanks, guys. Take care.
Thank you.